An 80-year-old male presents to the emergency department with central crushing chest pain. He has hypertension and is an ex-smoker. Examination is unremarkable and his observations are normal. An ECG is shown below. So there are 3 questions following this vignette. So question 1, which is the most likely vessel responsible for these ECG changes? Is it A, the left anterior descending artery, B, the left circumflex artery, C, the left main stem, D, posterior descending artery, or E, the right coronary artery? Question 2. What is the most appropriate initial management of this patient? Is it A, aspirin? Is it B, a Grace score? Is it C, high flow oxygen? D, percutaneous coronary intervention? Or E, take a troponin? And then finally question 3. Which of the following medications are not considered initially as part of secondary prevention for further myocardial infarctions? Is it A, amlodipine? B, aspirin? C, atorvastatin? D, bisoprolol? Or E, lisinopril? So for question 1, the correct answer here is B, the left circumflex artery. The ECG shows T-wave inversion in V5, V6, EVL and lead 1. These are the lateral leads, commonly supplied by the left circumflex. The image here explains the ECG territories and the responsible coronary vessel. Looking at question 2, the correct answer is A, aspirin. Aspirin is the unsung hero really of ACS treatment and should be given as soon as possible at a loading dose of 300 milligrams. It's a safe and effective antiplatelet. Looking at the incorrect answers then, so a Grace score is used to assess the risk of further MIs in the next 6 months and therefore whether angiography is indicated. It is completed after the diagnosis of an NSTEMI or unstable angina is confirmed, normally by the cardiology team. It needs both troponins to be completed, so it can't be done now anyway. Option C, high flow oxygen. It's not indicated as the SATs are within target range. We know that hyperoxia can worsen infarcts through several mechanisms, the first being increasing reactive oxygen species, which directly damage cells. The other involves reversing the body's natural vasodilation to ischemic tissue. When tissue is hypoxic, vasodilation increases blood flow to that area. If excess oxygen is given, the tissue suddenly has more than it needs, and this causes vasoconstriction, ultimately worsening infarcts. So PCI then, PCI is indicated acutely for ST elevation MIs or after a Grace score is completed for NSTEMIs and unstable angina. It's therefore not required currently. And then option E, taking troponin, a sensible thing to do and absolutely would happen in practice, but delaying the aspirin to take and then wait for a trop result is bad for the heart and bad for the patient. Remember that blood results will take at least an hour to come back, so get the aspirin on board first. Looking at the answers for question 3 then, the correct answer again is A, it's amlodipine. So amlodipine is a calcium channel blocker that lowers the blood pressure by vasodilation. Now, although managing hypertension is important as secondary prevention, an ACE inhibitor is preferred because it also helps prevent cardiac remodeling. Looking at the incorrect answers then, so aspirin is needed as a maintenance dose of 75 milligrams for life, alongside a second antiplatelet normally for the next 12 months. Atorvastatin, a staple of lowering cholesterol. Statins reduce cholesterol production in the liver. Atorvastatin itself may have a role as an anti-inflammatory medication during and post-MI, although the jury's out currently, more evidence is needed. D, bisoprolol. Beta blockers are negative inotropes and chronotropes. It therefore reduces myocardial oxygen demand, which is important for post-MI patients. And E, lisinopril. As mentioned before, ACE inhibitors help control blood pressure and prevent cardiac remodeling. Angiotensin II promotes myocyte hypertrophy and fibrosis. ACE inhibitors prevent the conversion of angiotensin I to angiotensin II, thereby reducing this cardiac remodeling and the risk of cardiac dilation and hypertrophy.